Welcome to the meeting for October in beautiful Fresno. Let's have the roll call.
Dr. Klingberg.
Here.
Dr. Drusis.
Present.
Dr. Grant.
Here.
Diana Woodward-Cable.
Here.
David Johnson.
Here.
Jennifer Laredo. Here. Christy Pulowski. Here. Dr. Pollard.
Here.
And Dr. Sullivan.
Here.
All right, everybody is in attendance and we have established a quorum. We're on to item number 2. Let me say I'm going to probably be flip-flopping items 5 and 6 here and moving student exemption up and moving the premises discussion, the shelter medicine discussion down, not premises, but shelter medicine down. That will be based on audience members that are here and have other obligations. So that's to be announced as we move forward. Also, for once, we have a meeting where there may be more wild animals outside the building than inside the building. We're all going to try hard to not get distracted, but what those of you who are watching this from home can't see is that we have lions to our right and rhinos to our left. And it's a beautiful setting here. So those are my remarks. Committee members have an opportunity to say something, and then we will have introductions from members of the audience if you so desire. Anything from the committee? All right. Would you like to introduce yourself, members of the audience?
Cheryl Waterhouse, Subject Medical Board.
Leah Schubach, CDMA, Committee.
Val Tenspin-Maker, CDMA.
Grant Miller, CDMA.
Bonnie Boots. Erica Buda-Shack.
Leslie Bureau-Parker.
Nancy Early-Parker. Ben Baker.
Ethan. Eric Anderson, California Control Association.
All right. Thank you, everybody. Moving on to item number 3, review and approval of the July 25th, 2017 committee meeting minutes.
So we have a couple of changes. Page 2, under item 6, change ceased to ceased under Penal Code 597.1. Page 3 of 9, last full paragraph starts with Ms. Welch advised that the intent and terms, and it should say regarding shelter staff euthanasia of wildlife, could be clarified through frequently asked questions.
So that last one again, intent and terms.
Regarding shelter staff euthanasia of wildlife.
Okay.
And those are the corrections on that.
Other committee members, addition, subtractions? Yes.
I just have a question in 2 of 9, under 4. I don't know that Dr. Jeff Pollard and William Grant noted because Dr. William Grant was not present.
You're right. Just Dr. Pollard. You were channeling something. You were channeling.
You may have noted on his behalf.
Yeah. And we'll change that to he and Dr. Grant.
I've got one
Tara?
on page 5, item 7. 5 paragraphs down, which is really just one sentence. It says, Ms. Welch stated that the regulations should provide guidance, and should actually be changed to are intended to.
How is the audio for the audience? Are you hearing everybody okay? It's hard for us to gauge, okay? And then videographer, how are we doing? Audio's okay there? Okay, great. So it seems a little quiet, but
Yeah, it does appear.
okay. All right, any other additions, subtractions, etc. to the minutes? A motion to approve, please.
So moved. Second.
Motion and second. Any discussion from the committee? Discussion from the audience? All in favor of approving the minutes as amended, say aye.
Aye.
Yeah.
Oh, yes, yes,
Like-
sorry. Yeah. Oh, the good old days. Thought I was
Long
going to
gone.
sneak that in there.
Long gone. Dr. Klingborg.
Aye.
Dr. Druces.
Abstain.
Dr. Grant.
Abstain.
Diana Woodward-Hagel.
Aye.
David Johnson.
Aye.
Jennifer Laredo.
Aye.
Christy Pulowski.
Yes.
Dr. Pollard.
Aye.
And Dr. Sullivan.
Aye.
Motion carries.
Okay. Item number 4, discussion and consideration of extended duties for registered veterinary technician regulations with a potential recommendation to the board. We did have a subcommittee that looked at this, Christy Pulowski, RVT, and Jennifer Laredo, RVT. I would like to hand that over to the two of you to kind of walk us through this. I would also like to add a discussion that has been assigned to us but wasn't covered specifically in this topic, and that is casting and splinting under indirect supervision, which has come before us a couple of times. And the board has given us the authority to discuss that. So we're going to discuss whether or not we're going to discuss that after we've discussed these other things. And then if we're going to discuss it, then we'll move forward with whatever we discuss. So I just wanted to give you that. And this week is next week, last week. All right.
Okay, so we've been discussing extended duties for RVTs for quite a while, and several concerns were brought up, several recommendations were made. It seems that there are multiple individual tasks that are being brought up that are of concern, and in my opinion, it's morphed from extended duties for RVTs to more of exclusions for veterinary assistants. In July, the last recommendation was brought up by CARVTA that veterinarian should delegate only to an RVT placement of a needle into a blood vessel or body cavity. And we, after researching that, we discussed it and felt that it was, it would inhibit, it would restrict access just specifically for those tasks. There are several things like vaccinations and in-house viral testing that could be done safely by an assistant if a veterinarian deemed them capable. The other thing that was brought up was to clarify induction of anesthesia to include not just injectable, but inhaled, intramuscular, subcutaneous, topical, and oral. So we do have a recommendation on how to clarify that language. And the last thing that we should discuss is, because these individual tasks do keep coming up, is this really a continued discussion on extended duties for RVTs, or should we discuss exemptions for for veterinary assistants in the interest of consumer protection? So that's where we are with everything. Questions, comments?
I have a question.
Well, I know that we presented this language to, as far as the induction, and I know that it's going off the agenda, but I know that in the premises task force that also has a meaning of, or they clarified induce as well. So I want to make sure that we are looking at both things when we talk about that. I just want to make sure we talk about both meanings.
Yes, Bill.
So you have here induce, should that be induced general anesthesia? Because you've got also topical and oral routes. Topical is done very routinely in veterinary hospitals by unregistered assistants. Topical, like proparacaine in an eye.
By veterinary assistants?
What's that?
By veterinary assistants?
By veterinary assistants, yeah.
Yes.
Yeah, topical.
Right.
So, and including wound care. I mean, you're using bupivacaine and things like that on a bandage change on wound care. So, I think that the intent should be induced general anesthesia, and if that's the case, then topical and oral routes probably also fall out unless there's some reason for that I'm not understanding.
I think the reason for it was I basically plagiarized it from the ABMA guidelines. The ABMA has listed all of the tasks for every state, so I copied and pasted and moved things around and came up with this product.
That explains it.
Pretty simple.
So,
Tara.
when you're deliberating about whether or not to make this change, one consideration is the necessity of it. And by that I mean, does this list incorporate every method of induction of anesthesia? And if so, then why do we need to list every method? In effect, how is the existing regulation failing to incorporate every induction of anesthesia?
I believe the concern was that the regulation was too broad, just induce anesthesia, so it wasn't clarified if it was general, if it was local, and there were concerns brought up by the organizations that unlicensed staff was performing some of these tasks, so there was a request for clarification. So
I think that's why, I mean, I get it and I understand. I'm not against clarification, but I get concerned when we get too prescriptive, because when we get too prescriptive, we actually get ourselves in trouble. Because if we get too prescriptive, then what happens when something new comes out? Then we're stuck because it's not included on the list. And so, I mean, I liked it. I'm not going to throw Jennifer under the bus because I liked it and I'm supporting this. And then I was like, but I start thinking about it, and I'm one that's like, okay, if it's not included on the list, then what do we do? So I am a little concerned about, if we're not general, you know, then what do we do? So is there a way to make this very general?
Dick.
I like the idea of maybe putting the word general anesthetic in there, and as Bill suggested, and leaving the rest out. I think that makes it more specific as to the intent, but leaves the methods
Right.
available.
We're able to get more prescriptive without.
So I want to take a step back just to kind of provide some framework to this discussion that we're going to have. And I'm referencing your report in which I identified 4 different topics or action items. And they were the discussion about penetrating a body cavity or vessel. Okay. They were a reference to epidural space and whether that should be restricted to DVM only. They were the RVT induction of anesthesia. Also, you had a for discussion point about should there be some restriction or prohibition of veterinary assistance on invasive procedures, and then I've added the casting and splinting. So just as we kind of go through our checklist of what I'm expecting we're going to be discussing in this agenda item. At this point, and correct me if I'm wrong, but at this point, we're discussing what I have as item number 3, restricting to RVT the induction of anesthesia by any means. And so the question has come up, are we talking about general anesthesia or local anesthesia? And so what are we talking about? Is when it says anesthesia, what is the intention there?
I think it's general anesthesia. That's what we're talking about. And I think it's broad enough, and it gets to the intent, and it also addresses what Christy's saying. I mean, if there's when new things come out and everything else, it's still, if the intent is general anesthesia. I believe there has been discussions with legal with regard to what is the intent, and we had that discussion where if you give so much Tilazol, for example, that's sedation. If you give more, that's an intent to induce anesthesia. So induced general anesthesia is, I think, what we're talking about. It's how specific do we want to get? And, you know, if you're talking also about doing, say, a spinal tap, anything like that, that you would, you know, use anesthesia for, that's not addressed in here also. So general anesthesia, I believe, is what we're talking about.
Yes, Alec.
And I don't know if there are RVTs or veterinary assistants that will be doing this, but certainly for the sake of consistency and the overarching discussion, diagnostic nerve blocks are certainly inducing a layer of anesthesia, and they heretofore have not been mentioned in this discussion.
So, Bill, are you suggesting that this language says induce general anesthesia and just stops there without enumerating?
I would say general anesthesia by any means.
Okay. Induce general anesthesia by any means.
So in 2036, we're talking about what is restricted. And we're clarifying that B1 refers to general anesthesia. So the route of administration of the general anesthesia, are we saying if we're talking about general anesthesia, there's no need to clarify that it's intravenous, intermuscular, or subcutaneous? Is that what we're saying?
Right.
That general anesthesia would be those methods only, and so it is explicit to say induce general anesthesia.
And you could use just induced general anesthesia, period, or general anesthesia by any means.
David?
Yeah, I don't think we need to go much further than just add the word general, because in 2034, induce is very clearly defined, and in 2032.4, general anesthesia is very clearly defined. So I mean, we spent a lot of time years ago defining these things, and it's held up just fine. And those arguments we're having today were the ones we had when we did these original regulations. They seem to be working and holding up, and if you need clarification and, you know, put an adjective in general, that would be fine. I don't think you need to go any further, because we already have everything else covered in existing regulations.
So I guess that begs the question, are we seeing an issue with veterinary assistants inducing general anesthesia? So what prompted the need for this change?
I don't know that we are seeing an issue. It was something that was brought up, I believe, by CARVTA as a concern. I don't know the statistics on what complaints there has been, but it was very broad and very open to interpretation. And looking at the AVMA guidelines, what each and every state lists for duties of veterinary assistants and registered veterinary technicians, it was more clearly defined in many other states. We had the most, I would say the shortest
Yes.
description of just induced anesthesia.
Right.
It wasn't clearly defined.
Definitely.
Okay, I guess, and the reason I'm asking is I think all of us are aware of how arduous it is to get regulations through. That shouldn't be necessarily a deterrent, but it's not from a complaint-driven standpoint that we've seen this as an issue. So I'm just understanding the background, because as we write these regulations, one of the tasks, the major tasks for staff, is to explain an initial statement of reasons, the justification for why you're changing something. So if this was a clarity issue, I guess perhaps this makes it less of a clarity issue. But in terms of this being abused, or we see veterinary assistants inducing general anesthesia, if that's not the motivation behind it, you know, we really got to look at how much time and energy we're going to spend to put forth a regulation if this isn't an issue. I just want the committee to think about that.
I don't know that we have facts to back
Okay.
up the
necessity.
The necessity.
Okay.
So let's get public comment at this point on this specific topic, and then we can figure out how we want to move through it. Yes, please.
Bonnie Lutz. I defend veterinarians in administrative actions. Most of you know that, but that's for the record. I wanted to touch on what Anne Marie and what Dr. Grant said. I agree completely that it should be left the way it is as far as induced anesthesia. I also agree with Anne Marie that the regulations are difficult to pass, and I'm frankly not seeing a lot of cases of vet assistants inducing anesthesia now. I would say 10 years ago, half of my work was that. Now people are aware of the fact that since the induced language went into 2034, it's really clear what vet assistants and RMTs are able to do. Everybody seems to understand what induced anesthesia means because it is defined in 2034. So I think it's better to leave it alone, and I'm glad you took out topical and oral, because that was just going to cause another whole problem. Thank you.
Other comments?
You know, as this was brought up by CARVTA, I'd like to hear CARVTA's opinion, if either of you would.
Good morning, Leslie Boudreau from CARVTA. One of the things that we are seeing is, as was mentioned, I think, by Christy, is that there are a lot of new modalities out there. We're commonly seeing technicians being trained in epidurals and local nerve blocks, but there is no restriction on lay staff performing those right now. An epidural is, you know, there is not a specific classification of whether that is considered a general anesthetic or a local anesthetic. And so that it creates a gray area that then creates self-interpretation. So in individual practices, they're going to interpret that however they see fit because it's not specific. It doesn't specifically discuss those modalities. Local nerve blocks can certainly be very problematic if done by non-trained, inexperienced staff. And so would we be comfortable getting an epidural for our own self by a layperson? And I don't think anybody would agree with that. And so RVTs are being trained in these things now. I attended a CBC wet lab in San Diego last year on the administration of epidurals, but there was no restriction on who could attend those, that training. So I think that's where we're going to be faced with these type of issues if we are not specific in what these things mean. There isn't, you know, again, it's a gray area that we're going to, you know, potentially lead to problems with treatment of pets, and I can foresee this as this becomes a more frequently used modality of issues with danger to pets. So I think that's where CARVTA would like to see that, especially these newer modalities, are restricted to RVT or DBM only, or RVTs under, you know, the direct supervision of a veterinarian. There just are a lot of changes in what we are being asked to do, but if we are not restricting it from a layperson, then this is where these issues occur.
So if I'm understanding, it's more of an anticipated threat to consumer protection rather than a current issue.
Well, I don't particularly know of any cases that has caused injury to a pet, but I can foresee that in the future. Just with my own experience of the lack of training of staff that are being potentially asked to do these procedures.
Yes, Christy.
But anybody can attend the training, so they're allowing anybody to attend the training?
Yes, there was no requirement.
But they're getting training.
So they're getting training potentially, but that doesn't mean that there's somebody performing it in a veterinary hospital that hasn't had training.
Right.
Because there are no restrictions.
My challenge here is that in this phrase induced anesthesia, I think we're having a discussion about anesthesia, local, epidural, general, but the key word in that phrase is induce. And we've defined induce as to render an animal unconscious. And so, unfortunately, the changes that I think you're asking for and are anticipating, they're in no way affected by what we're discussing here today, because we're not actually discussing local or epidurals in any way, shape, or form. So I get what you're after, but I don't think this is the right segment, the piece of language to do that, because we have so clearly defined induce.
Right. Yeah, I agree. I absolutely agree. I don't.
So this goes back to the extended duties as well for RBTs. Is that, should that be an extended duty, which is where CARFTA, brought that as one of the extended duty tasks. So and I know you're saying, is it more a restriction or is it an extended duty? I believe it is an extended duty. If you're saying that it is not the language of inducing anesthesia, we spent a lot of time looking at the way other states, list their duties for technician. And, just for example, New York State lists inducing and maintaining anesthesia. So they go beyond the induction to the actual maintaining of anesthesia, which is not something that's currently restricted in the state of California. And I currently see in practice the induction, and then the technician walks away and there's a lay person maintaining anesthesia. So, again, that clarification of what exactly is the role of the technician in the anesthesia.
I would just like to add that this is supposed to be a discussion about what the potential changes to the regulations should be, and nobody is limited to any particular language that was proposed in a previous meeting. That you're perfectly capable of creating new language at this meeting, which would be necessary. Any new language created at this meeting could include what Leslie was talking about nerve blocks and other types of anesthesia, delivery of anesthesia. Obviously, the word induction is not appropriately used with these more local anesthetics, but clearly you could come up with some kind of language that would be appropriate.
I think, a couple things. One is that CARFTA did give us a proposal with a whole bunch of different tasks, and some of those were nerve blocks and things of that sort. And at the last meeting, CARFTA asked this group to not discuss that language, but to discuss the language that's in front of us today. So, first of all, that was all on the table, and CARFTA took that off the table. The second thing is, Nancy, you understand how agendas work. We have an agenda, and we do have to agendize the topics that we're going to discuss. We cannot have a brainstorming session up here. We do work within some constraints. So,
I'm not aware of that being the rules of how this committee works, that you were discussing extended duties. And why can't you discuss extended duties that are not exactly the words that were presented at the last meeting?
So, if I can interject, the document that at the last meeting, CARFTA did recommend that the board consider, as opposed to the laundry list of tasks, that a statement that reads, a veterinarian may delegate only to an RVT any procedure involving placement of a needle or appliance into a blood vessel, body cavity, or epidural space.
Okay, so there you go.
Okay, right. So Nancy, let me finish my statement and then you can respond. So that is something that, Leslie brought up. That is part of the discussion. And the subcommittee in the document rendered its opinion about that. And they then suggested that based on things that they reviewed from the AVMA position statements in other states, that perhaps the clarification where needed was specific to anesthesia or induction of anesthesia. You're right from the standpoint that the statement that CARFTA recommended the subcommittee or this committee look at is still part of the agenda topic. So that statement is still part of the agenda topic. How we've segued from there is the recommendations of the subcommittee. So they did not feel, based on their research, that this would in fact be an appropriate way to regulate who can and can't perform procedures that may in fact invade a body cavity. Instead, the focus was anesthesia. So you're right that there is room for you to comment on the statement that CARFTA recommended, The reason we transitioned to the anesthesia piece is because the subcommittee, in their report back to the MDC, did not find that statement to be, in their research, something the committee should pursue.
Yes, and you intentionally created a two-person subcommittee that met in private where there was no opportunity for anyone to comment on their position. And so now this is brought to the public.
Right.
And this is where this discussion should be occurring.
I would like to state that we did actually have the list, the original list, and it included all of the original items that were brought forward from CARFTA, and we discussed those at our last committee meeting in July, and we did extensive research on those. Jennifer and I looked through all of those. Do you agree, Jennifer? And we went through all of those tasks, and those were originally your list, and I think we did our due diligence in looking through all of those tasks, which were included from you. And so it isn't just listed to the current items. And so I don't want it to seem like it's just now just down to these two things, because we had a whole other list of items that were brought forward to this committee. We had other items that were included from CARFTA that we did research on. And now we were brought forward more items. So it doesn't just stop here. We had other items that we did research on.
I just wanted to clarify that, Dr. Grant discussing of general anesthetic leaves out the other modalities of anesthesia. And that's where we have the concern. By, stating that it only is general anesthesia, then it leaves open, again, the gray area of these newer modalities that are being utilized on a daily basis with no direction in practice to who can perform these procedures.
So again, I had identified 5 different topics in this particular section here, and the first one was the language involving penetrating a body cavity or blood vessel. The second was the epidural recommendation. The third was where we are right now, which is induction of anesthesia. Fourth was the discussion about veterinary assistant prohibitions, and the fifth is casting and splinting. We're kind of on number 3 right now. We have morphed into discussing the first topic, which was the original language, the new language that CARFTA asked us to discuss. So can we finish with number 3, the induction discussion, and then move into a little bit more detail on the penetrating a body cavity or blood vessel discussion and thought process? Where are we with number 3? About changes, adding general anesthesia? Let's discuss.
I feel it needs clarification in some form or another.
Okay.
And that's my firm opinion.
Yes.
I think we need to discuss, are we limiting our consideration to general anesthesia or anesthesia by any means, which would include general and local, epidural, and the like.
Again, my challenge here, Alan, is the word induce, because we've defined induce to mean unconsciousness. And so that's what's hanging me up here. I get the difference between local anesthesia and general, and I think that it's a very good discussion to have. But because it is pegged to induce, we're talking therefore about animal unconsciousness. So maybe there needs to be another line here, okay? But that's where I see that we're at. Dick.
Again, going back to consumer protection, regardless of the task in all of this discussion, it is ultimately the supervising veterinarian that has the responsibility here. And for consumer protection, we do have that license to go after. So there's not a void out there. There is a framework out there. This discussion is maybe specifying things more or making things more clear, but I have no problem with how things are written right now.
Do we have a motion from the committee?
Do we need one if we're not changing it?
Well, no, we do not. So if we have no motion, then we will assume we have,
I'll make a motion.
all right.
I move that we explore altering, perhaps clarifying the description of 2036B1 induced anesthesia. Perhaps a more collaborative subcommittee could be assigned the topic to explore the possibilities of it. Maybe bring something back in February for discussion amongst the committee.
I just want to add that if the president of the committee wants to create a subcommittee, it doesn't require a motion. But I think that might be an appropriate suggestion for the committee's consideration.
But again, I don't think we're discussing, I mean, I don't think this discussion was about inducing general anesthetic, is it?
That's what I was gonna say, it's not for, it's what he's talking about, right? Is that what you're talking about, Jennifer?
Yeah, the actual regulation for induced anesthesia, that's the one that I have a problem with, that I don't feel is clear enough. Just the two words induced anesthesia that are in current regs should be clarified.
Just a reminder, in terms of broadening the subcommittee, we're restricted to 2-member committees unless we're going to notice it and have it as a public meeting. Restricting it to a 2-member committee does not mean that you cannot invite comments and suggestions from outside organizations. But in terms of expanding the number of members on the committee, that would require public notice. I just want to remind the MDC of that.
Mr. Chair?
Yes.
Might I suggest that we restrict our discussions today and our potential motions to general and induction of general anesthesia, and then leave any other type of anesthesia, that would be epidural and local anesthetic, to the subcommittee to bring back something relative to that at our next meeting.
Jennifer, your motion does not have a second at this point. Okay, there is a motion on the table to restrict today's discussion to general anesthesia and to create an agenda item for the future, which I'll ask the board for permission to discuss local anesthesia or other forms. Yes, Diane.
Well, I'd like to throw in my 2 bits. It's way beyond what I know about, but I consider myself a wordsmith, and I learned something today, and that was induce means to render unconscious. And I did not know that. It's sort of like the word endorse, which is signed on the back, and how many people say endorse on the back of the check. So I'm going to say, maybe when you're looking at the language and you're expecting people, including laymen such as myself, to know what they should or should not do, to add a little bit of clarification about what induction or induce means.
It is in there.
Well, it's not in that phrase.
It's in
Well, yes. And that's always been my criticism. But I'm just saying that. Thank you. I learned something.
Do you have a motion? Also without a second at this point. Okay, so here we are. We've got this, and in general, the lack of motion suggests that we have discussed this issue and we're moving on.
Just for clarity's sake, then, there is no modification to 2036 B1.
Yeah. Barring a motion after I'm done talking by somebody on the committee, we will be done discussing 2036 B1 and any modifications of that. This is your 10 seconds. All right, so we're going to move up to what I have identified as the first item, and that is the second paragraph of the report from our subcommittee. It is the opinion of the subcommittee that to restrict the RVT and DVM any procedure that involves a needle penetrating a body cavity or blood vessel would potentially limit access to veterinary care. Many such procedures as vaccinations and in-house diagnostics can be safely performed under supervision by trained veterinary assistants who have been deemed competent by the supervising veterinarian in accordance with CCR 2035, duties of supervising veterinarian. Subcommittee, any further discussion, clarity, information on that? Public comments? Okay, we will move forward. The next paragraph down, a needle penetrating an epidural space is invasive and arguably a surgical procedure with great potential for harm. This task should continue to be restricted to DVM only. Is it restricted to DVM only was my question when I was reading it.
No.
It isn't.
It should be.
I think that there's different kinds of epidurals. I'll say in my dairy career, we gave many epidurals to cows to get them to relax so we can manipulate calves and hold them safely from the mother. And that was not a particularly difficult procedure, and it was one that a layperson could certainly have been taught to do with a very low potential for harm. And those calves could not have been pulled without that procedure, which would have created real harm to the poor cow and her calf. They both would have died. So while that was traditionally a veterinary-only procedure, as dairies have become more and more sophisticated, that has changed. And that is a commonplace, probably the most common form of epidural that's actually performed in the state of California is in the dairy industry.
I think the concern was small animal epidural. It wasn't clarified.
Yeah. So do we want to clarify that?
We can't look at things though just as small animal and large animal. We have to look at it as a whole, so we have to.
So at this point, I would say leave it up to the supervising veterinarian to make the determination.
Dr. Pollard?
I have a question. Leslie mentioned earlier about the wet lab at CBC that taught epidurals without restricting, the audience. I have never seen in my travels anybody but a DVM do an epidural in a small animal. So my question is, has anybody else? Interesting.
Do you want? Yeah, please.
I think it's becoming more common than,
Leah Schupel, CBMA. I went to Michigan State University for my bachelor's degree for technician school, and we were all taught as technicians to do epidurals for blocks for any caudal abdominal surgery, and all the technicians did them exclusively for pain management in the surgical department there. So that was routinely taught to all the technical staff. Back then, in the early 2000s, I don't know what they currently do, so that is for sure.
Grant Miller, CVMA Director of Regulatory Affairs. In the context of my employment at CVMA, I often take calls from veterinary practices that are looking for help interpreting the regulations. And very commonly, I would say probably 2 or 3 times a year, I get contacted by neuro-specialty practices or lameness sports medicine specialty practices that inquire about whether or not they're officially allowed to have their paraprofessional staff perform epidurals. So my assumption, of course, is that they're already performing epidurals. And for them, they view that as an auxiliary healthcare task because in the course of their practice, the scope of what they do, it's very common that they do those every day. So their folks have specialty training in it. They're very well versed in it. So it does occur, though.
So, color me surprised, but maybe not so much if that is the audience who are querying whether that can be permitted. These are very specialized people who probably have their thumbs on the duty very closely, and also, back to Dr. Sullivan's comment, it still lands on the veterinarian.
Yes. David.
I just want to clarify from Dr. Grant, were they saying their veterinary assistants wanted to know if their veterinary assistant could perform the task or their RVT?
I don't specifically recall in every instance. I think the last one that I had was an RVT that they were asking, was it okay to do? I couldn't tell you over the course of the years how many of them clarified that.
Thank you.
I would just like to remind you that...
Please identify yourself.
Oh, Nancy Ehrlich, California RVT Association. I would just like to remind you that any particular individual can probably be trained to do just about anything. I'm sure that if I spend enough time learning how to do cat neuters and spays and dog neuters and spays, for that matter, that I could do them probably better than some of you, because I have very good hand-eye coordination. But that's not the point. The point isn't that an individual veterinarian has the responsibility for each person working in their practice. The point is that you have the responsibility. The Veterinary Medical Board has the responsibility to determine which procedures should be restricted to people who have particular qualifications. So I don't think that it's helpful for you to, every time a procedure comes up, to say, well, we know people are doing that, and that veterinarian is training the staff. It's up to you to decide on a global basis which job tasks should be restricted to people who have the training. And just for your edification, I brought a copy of the New York State job task for what they call LVTs. And you'll notice that in New York State, a veterinary assistant, the only job task which they are allowed to perform legally is administering oral medication. Every other job task in a veterinary hospital that is not restricted to a veterinarian must be performed by an LVT. And the surprising thing about that is they actually have more LVTs per capita than we do. They have half the population and many more RVTs per capita. So by restricting job tasks to licensed personnel, you don't actually end up with fewer licensed people, you end up with more. So I just hand this out.
So we have a suggestion, recommendation from our task force here regarding epidurals, and that this should be restricted to DVM only. How does this committee want to move forward with that recommendation?
I stand by my recommendation. I feel it should be restricted to DVM only.
Bill?
Some of the problem here is, again, we are getting rather prescriptive. I mean, where does this list end? Do I think that this, for the most part, should be restricted to a veterinarian? The answer is yes. But what else is there on that list? How extensive is this list? And now, if you have an extensive list, and maybe this is a question for legal, if the list is extensive and there's something not on there, then you would say, well, there's a reason it's not on there, and that it's not restricted.
That's right. There will be presumption by someone that because it's not on the list, then it's either okay because it's not on the list, and if it's a prescriptive list, then, and it's not on that, it's fine to perform. Alternatively, if it's on a list, then some people will say that, oh, I can't do that. So yeah, when we start going down the path of creating lists, it really does start to create more of a perception and understanding problem later, I think, which is why the existing RVT authorization statute is very sparse. It's there's not a lot of extra words to it. It's small.
David?
I just wanted to get a point of clarification because I'm reading this statement. It says this task should continue to be restricted. I'm having trouble with the word continue because to the best of my knowledge, there's never been a ruling that said epidural is a DVM only task. And so I don't believe that has ever been issued by the veterinary board, and I don't think the veterinary board has ever ruled that an epidural is surgery. Now, if that's the direction they want to go, that's another discussion, but I don't think currently that exists anywhere in any of our statutes or any of our regulations. Which again opens it back up then, if it isn't restricted, then a veterinary assistant or an RVT or the receptionist at the front counter under the supervision of a veterinarian can perform that task. But the veterinarian would most certainly have to be totally responsible for it and justify it in the eyes of the board if something went wrong.
Do we have any motions on this item? Because the Practice Act, to my knowledge, is silent on the issue of epidurals.
Very silent.
I mean, it says supervising veterinarian is as specific as it gets. No? Yes. Yeah, thank you.
What we're looking at here is a standard of care issue. So, you know, we get really caught up in the regulations, and I agree with counsel that we don't want to get too specific. I deal with this on a daily basis with my clients saying, well, it's not specifically excluded, so that means I can do it, but then it gets into a standard of care issue. So if it is below the standard of care for a veterinarian to allow a certain person to do an epidural, then that veterinarian will be called to task for conduct below the standard of care. So there's regulations, but you can't direct everything with regulations. There's always the standard of care issue, and I believe that this is the standard of care issue.
To that comment, Bonnie, I agree with you for the most part that we look at these things in terms of what is the accepted standard of care. Where we struggle sometimes and where regulations are helpful is when it's not an accepted standard of care. So we've heard that, you know, in this discussion, I think some of us learned some things that it may be an assumption that this is only restricted to a veterinarian, and those that are practicing cautiously would not delegate this to someone else. But we've heard there's training going on. We've heard that there are cases where, you know, the association is getting questions about who this can be delegated to. So when there is an uncertainty about whether it's an accepted standard of care in the state of California for only a veterinarian to perform a certain function, then you may need something that is more defining, more prescriptive. And I think we're trying to figure out, is that where we're at today? What is the accepted standard of practice in this area? Is it that only a veterinarian would be administering an epidural? Or is it something that's really open to interpretation, and we're seeing that there is some disagreement on whether or not that is truly standard of care? I don't know the answer to that question, but this discussion alone is generating some question as to whether or not this is an accepted standard of care, or whether we just have some individuals who say, I wouldn't delegate that because I'm not going to take the professional responsibility if something goes wrong. The degree of risk obviously is much higher in an invasive procedure where you're talking about, you know, nerve endings and things that could be extremely harmful to the patient. So I agree that we do have a responsibility when the risk to the public is greater than the benefit in terms of doing something to hopefully avoid creating risk to the public is greater than being silent because we want to make sure that we're recognizing that there's a standard of practice that's going to continue to evolve. And that's the balancing act that we're trying to do here. The practice is going to continue to evolve. The standard of care changes over time. We're all aware of that. But is this an area of practice where we as a consumer protection board need to be responsive to the fact that we don't have an accepted standard of care, and then we have to do something more formative? And that's really the question.
Dick.
The problem with that in this case is that we have two different standards in large animal and small animal. And I just hate going down that road of differentiating between the two. So I think it does come back to the supervising veterinarian that has that responsibility. And those clinics that are not doing this routinely, it better be done only by a veterinarian because that is the standard of care If it's a specialty practice, I think the standard can be different. But I think particularly with John's example of the large animal world, we've got to be really careful with this topic.
Has the subcommittee done research specifically regarding this epidural issue with how other states are handling exclusions?
I did not. I know that I didn't look at the states. I didn't look at the states. I have to, actually, that's what I was looking up right now, is to see what, I was kind of cheating, to see what I had done with the, because I have it in my notes, and see because I wrote in there the notes and the schools. So I was trying to see what I had done in my schools.
So arguably, if they're teaching this in registered veterinary technician schools, right? They're training RVTs to do this. It really does, that argument that it should be restricted to a veterinarian only. It's a difficult argument to make if they're training RVTs to perform these procedures. So Leah testified to that.
But that conference on school.
No, Leah had it at her bachelor's program.
Yes, it's actually, and I do have it right here that it is actually being taught. So, and that's what I was looking up. So I was looking at my notes too, and to review, and it is something that is being reviewed at schools.
So that's where I'm saying the standard of care argument is difficult to make here.
Yeah, it's also, I mean, we're really going to get into the weeds on this real quickly. I mean, there's a huge difference in a lumbar puncture and a cistern puncture. I mean, a lumbar puncture, there may be some, I don't want to belittle it, say, complications from that, but a cistern or a high puncture, you could either kill the dog or paralyze the dog. So, I mean, how technical are we going to get? I agree with Dr. Sullivan's comment about large animal, small animal. There are some things in the Practice Act that are different for the two. But, you know, what problem are we trying to fix here? Is there a problem that we are trying to address, that there is a consumer, related to that, a consumer protection issue? And I don't think there is. I haven't seen it. It's maybe an access question, but that's not what we're here for. We're here for consumer protection.
Dave? No. Do we have a motion on this topic? If we do not, then we are going to move forward. We've already looked at the next paragraph, so that takes us down to, in working off of the report from the subcommittee, a discussion item. Should CCR 2036.5 Animal Hospital Healthcare Tasks for Permit Holders and Veterinary Assistants be modified to state that veterinary assistants shall be prohibited from performing invasive procedures? If so, how would invasive procedures be identified? Comments from the subcommittee on that?
Yeah, in my opinion, that's become the issue. This has evolved from extended duties for RVTs to mainly exclusions for veterinary assistants in the interest of consumer protection. And I don't know how to define invasive. I was hoping to get some input from the committee on that.
Well, and I think, and in order to resolve the comments and questions and repeated issues coming up, I think that's where we have to, I think that's the issue we have to address is, you know, and handle.
There are definitions of this in the human medicine world. They talk about penetrating a bodily orifice. It sounds pretty disgusting, but it really does have a limiting factor to it in human medicine. And so there are some examples that we can take from the human medicine world. But invasive procedures, again, if you're not careful, injections could be invasive procedures. So you really have to decide what you're trying to tackle with that. Are we back to the epidural space? Are we back to something, can we define how deep the penetration is or the intent of the invasive procedure. Because really invasive means you're penetrating the skin, and that's how it's defined in human medicine. So I don't think the intent is to restrict vaccinations or restrict blood draws or restrict some of these other, forgive me for calling it perfunctory, but routine procedures, I guess, is a better way to describe it. But I would agree with Jennifer, if there is a potential, because of what we're seeing in practice, that we have individuals who don't have appropriate training, who are doing things beyond that of someone with, you know, the clinical acumen to understand the degree of risk that they're taking on, then we may need to do something more formative. You know, relying on supervision is only as good as the individuals who are taking on that responsibility understand the level of, and I dare say, liability that they're actually assuming. And yes, for the most part, when you have an independent practitioner who is relying on support personnel, you know, as Kurt used to describe this, you're the captain of the ship, and then you've got those that are working for you, and your degree of supervision obviously should align with the individual's you know, competency and clinical acumen. However, if there is something, and I go back to, that is unclear for even the supervising veterinarian, and I really take Grant's comment to heart because we get questions all the time. You know, auxiliary animal health tasks isn't well defined. And I'm not suggesting that we go back down that road, because I've seen documents from the 90s where we tried to define it and it was a nightmare. But I am suggesting that if the profession in and of itself needs further direction for the purpose of creating a level of consumer protection that we don't have today, then it's worthwhile considering it. And maybe this invasive procedures definition, whatever it may be, is one step in that direction.
David.
I have a slightly different approach and suggestion on this, and Anne-Marie kind of follows along what you just started to say. I'm thinking that maybe the best way to approach some of these issues that are coming up is the fact that, you know, we're in 2017, veterinary medicine has leaped light years ahead of when we did the original job tasks in the late 70s and the early 80s. And some of the things that we put into the regulations are still the 1979, 1980, 82 language. We might want to look at duties of the supervising veterinarian 2035. And right now, there's only 3 major A, B, and C's. And for consumer protection, maybe expand those definitions out more to be talking about competency and training and the staff who's performing it, and if it's an invasive procedure versus a non-invasive, or the risk of the procedure, and put language in there that if we're going to go with the veterinarian is always in charge of determining everything, then maybe we need to tighten that up to help define the standard of care a little bit better. And that's just a suggestion.
We did have a series of 7 questions that we used as a metric for trying to look at that list that Carta had originally sent to us. And in brief, question 1, does this procedure involve any element of surgery? Question 2, does this involve suturing tissue? Question 3, is the potential that extending or restricting this task impacts consumer access? If so, how? Question 4, does extending or restricting this task address an area of consumer need? Question 5, does extending or restricting create the potential or reduce the potential for harm? Question 6, is this a commonly recognized task for RVTs or veterinary assistants to perform, perhaps in other states? Question 7, is the RVT trained to perform this task as part of their formal curriculum? So, I mean, invasive is probably trying to define that may be like trying to define what's funny. It's gonna vary from one person to the next, but you know, trying to create a list of measurable and identifiable topics, or again, a metric, a tool. So we do have something there, and so if we were to try and run the question of the epidural through that metric, would that get us any farther down the road in terms of do we need to make a change or not? I mean, I don't know that we have the wherewithal to have that discussion in this group today. Dick?
I'm just sitting here thinking about consumer protection, and as I think back on the disciplinary cases that we've looked at over the last years, I can't recall any that involved an RVT, competence, or even a veterinary assistant. When something goes wrong, it is the veterinarian license that's on the line, and those are the cases we're seeing, whether he's delegated that responsibility or not. I don't see the other staff members coming to the board. Am I missing something?
Yeah, we've had cases, it's usually classified as aiding and abetting. So even if it's a veterinary assistant, you've got to remember they don't have a license. So what we're looking at is aiding and abetting the unlicensed practice of veterinary medicine. So you may not see it specifically as an incompetence or a negligence. It's usually a charge of aiding and abetting.
But it's the licensee that is aiding and abetting.
Right, and then in some cases, if the individual doesn't have a permit, and in the past they wouldn't have had a VACSP, then it's a citation for unlicensed practice, which you folks wouldn't see. So, I agree with you. We don't see a lot of cases where we have, and I think I talked about this at the last MDC meeting, where we have veterinary assistants doing spays and neuters, or we have veterinary assistants doing surgical procedures. However, we have seen cases where we have what we would consider an inappropriate delegation to a veterinary assistant. And the charge doesn't look like you would think it would look. It doesn't look like an incompetence and negligence. It may be unprofessional conduct, but usually it's charged as aiding and abetting. So,
what I'm saying is, it's working because we've got a license to go after, and that stops that activity.
Right, and that is a reactive approach. So I want to clarify that yes, we're talking about there is a reactive approach to this. And that's part of the equation. Sometimes there is enough evidence that we need to do something proactively, and sometimes there isn't. We got into this debate over animal physical rehab, talking about where the complaints are, and should complaints generate the board's responsibility in being proactive? It's part of the equation, but it's not the whole story. So, that shouldn't necessarily dictate that we do nothing, because we don't have a history of discipline where we've got veterinary assistants performing duties as veterinarians. It is one factor in the equation.
So here we are with this agenda item, now the CCR 2036.5. We want to provide some direction to our subcommittee and send them back to do some work.
And what would that work entail? Creating a list that we would have to modify every few years?
I don't think that was the suggestion. I think the suggestion was perhaps looking at how we define supervision and whether there's anything that we can formulate within the definitions in 2035 that would perhaps address risk. There's that avenue. And then also perhaps looking at other states in terms of how they define, restrict, explore delegating invasive procedures. And we can look at examples in human medicines of the definition to see if there's something there that may fit. But looking at other states is not a bad idea when it comes to, is there something that we're missing here that would provide more clarity for the veterinarian delegating the task? This isn't about taking the responsibility away from the veterinarian, but is there something that we need to do formatively to educate the veterinarian about delegating such tasks to ancillary personnel?
So Dave has made that motion.
I so move what Anne-Marie just said.
2035 to explore duties of a supervising veterinarian, looking at issues such as competency and training of staff, risk of the procedure, what is the standard of care both in California and in other states, trying to provide clarity for veterinarians on this issue of how they delegate tasks to staff, be they veterinary assistants or RVTs.
A second.
Discussion from the committee. Discussion from the public. Yes, Nancy.
Nancy Ehrlich, while I don't agree that we need to create a long list of job tasks that should be restricted to RVTs, because we've tried that in the past and it doesn't work, which is why we tried to come up with a definition, a broad definition, which clearly also is not working. Dr. Miller brought up a very important point, that if a particular job task is not on the list, then the veterinarian assumes that it's okay to delegate that to a veterinary assistant who they believe is competent, whether or not you all or anybody else thinks that task should be delegated. So it seems sensible that if there are particular tasks that are particularly risky, and everyone agrees are particularly risky, that are not on the current list, that we really should consider adding a few new tasks to this list if you're not going to be able to come up with an overall definition that is all-encompassing. And just to clarify, when we suggested invasive procedures, we were thinking of procedures like the various types of centesis, thoracentesis, abdominocentesis, cystocentesis, that we felt that a veterinary assistant, no matter how well the veterinarian trained them, should not be sticking needles into those spaces, because they have not been trained in anatomy like an RVT and all the risks that are potential with these procedures. And that these are the types of procedures that is the responsibility of the Veterinary Medical Board to restrict.
One quick comment, and time and procedures and drugs change a lot of things. I'm going to date myself a little bit. Rabies vaccines used to be intramuscular, and it was not that uncommon to see a nerve paralysis or palsy from getting a rabies vaccine. And this happened not unfrequently at vaccine clinics when you have a lot of dogs around and slippery things happen, and a client came in just to get a rabies vaccine, and now they can't use their right hind leg, and I've seen that. So again, I don't want to beat a dead horse, but lists, unless they're incredibly inclusive, which I don't think they ever will be, and times change, are going to probably be not the thing that this, at least in my opinion, this group wants to do.
We have a motion and a second regarding 2035. Any other discussion from the public? Other discussion from the committee? Roll call vote.
Dr. Klingborg.
Aye.
Dr. Druces.
Aye.
Dr. Grant.
Aye.
Diane Woodward-Hagel.
Aye.
David Johnson.
Aye.
Jennifer Laredo.
Aye.
Christy Pulowski.
Yes.
Dr. Pollard.
Abstain.
Dr. Sullivan.
Aye.
Motion carries. The other item is casting or splinting. The way that the 2036 is written right now, casting or splinting may only be performed under direct supervision of a licensed veterinarian. It has come before this group to consider whether or not that may be moved into an indirect supervision. And so that's the proposal, and now we're going to discuss it. Your thoughts?
I would not feel comfortable moving it to indirect supervision. I think we'd have to use some verbiage that we used before, at the discretion of the veterinarian, rather than carte blanche indirect. Unless that's already understood.
Isn't indirect, indirect doesn't mandate that it's done indirectly. I mean, it means it may be directly or indirectly. It includes direct. But.
I'm not sure, but it would suggest to me that if there was if there was a problem, the veterinarian can say, well, the regulation says indirect, so I don't have to be there.
Yes, Jennifer.
Do we have any background on this topic? Was it an access issue, or
Yeah.
where did this come from?
Will, yes?
No.
No? No. Yes. We've got David actually, and then Alan.
Well, a couple of comments real quick. Anytime we write definitions or regulations, they're permissive, they're not mandatory. So, Dr. Sullivan, if in your hospital, if the regulation said you could put a cast or splint on under indirect supervision, and the standard of care in your hospital for the staff you were supervising, you say, I have to be present for you to do that, then that's the standard of care. But there might be another facility where the staff member has had extra training and has gone to some of the CVMA bandaging wet labs and has had additional training, and therefore then might have that level of skill that could do it under indirect supervision. And then I'll shift to the world that I lived in for the last few years, which is the shelter community. And I can tell you that the RVTs in the shelter community routinely put on casts or splints to prevent further damage to an animal that has received trauma until such time that the veterinarian can examine that animal, or that animal can be moved to radiology to determine the full extent of the injuries. And so there is a reason to allow it to be done under indirect supervision, because it is occurring out there, but it is an issue that I think just needs to be clarified in terms of the circumstances. And to me, there's a difference between putting on a cast or splint as a semi-permanent treatment to correct an injury versus a cast or a splint to prevent further injury until the animal can be totally evaluated. And so maybe it needs to be split out into two different types of applications.
I agree with David for exactly the same reasons. I might add that in my mind, some of this harkens back to the discussion of sedation and anesthesia. Certainly, if you put enough bandaging on the extremity that renders it immobile, is that not the same thing as putting a splint on to temporarily immobilize until a veterinarian can examine the patient?
I'd look at 2036C1, an RVT may perform the following procedures under indirect supervision, and underneath that is administered controlled substances. I don't think we've ever interpreted that controlled substances may only be administered under indirect supervision. I think we may, within our clinic, specify that a fentanyl patch is something I'm going to be there to supervise the application of. So again, I believe that the use of indirect in this case is not meaning therefore it shall always and forevermore be solely indirect. Just that becomes an option. And in the case of a splint or cast to try and keep an animal from harming itself in a shelter setting, you may choose that application be indirect because you're not there and because
out of necessity.
Right, out of necessity. And yet, if we're talking about a fracture, a green stick fracture of a puppy's tibia, maybe we want to be supervising that one. I mean, I don't see that moving that in indirect creates any challenges other than it's still the supervising veterinarian that's beholden to make sure that it's the right type of cast or splint at the right time. So,
I'd just like to say that it looks to me like another situation where we've got something on a list that, with time, as Dr. Grant's been pointing out, changes and experience improves with support staff. I'm wondering if we remove apply casts and splints from direct supervision entirely, and then it becomes subject to subdivision D, which is indirect or direct. That might be helpful. At the same time, I'm also looking at C1, RVT may perform under indirect supervision administered controlled substances. There's only one thing here, and there's no requirement here. It's just saying, hey, we're telling everyone basically that an RVT can administer controlled substances under indirect supervision. This is also odd because I think the point of this is one of those, just like with epidurals, possibly, that something becomes so frequent that we have to put a list, put it somewhere so that it's clear. Because otherwise, administering controlled substances could be under direct or indirect under D. So why do we have it sitting there? We have it
sitting there because that means for a veterinary assistant to administer a controlled substance, it must be under direct supervision, and we are being more permissive with the RVTs.
Oh, right, because the VA regulation relies on the list provided under RVT.
And that's we'll get to you in a minute, but that's my interpretation of it. And then with 2036, in terms of applying splints or casts, my understanding was that meant that was RVT or DVM only. And if we strike that out, we are now opening up splints and casts to be applied by veterinary assistants. So that is why that sits where it does. Okay. Nancy?
While Nancy's coming up, I guess we'll need to make sure that if we're removing casts and splints, we'll need to consider the effect on a VA performing the same care.
The reason controlled substances is mentioned is because of the statute that allowed veterinary assistants to it. The statute says that both RVTs and veterinary assistants may administer controlled substances under direct or indirect supervision. So that threw it back into this section for clarity's sake, I guess. Whoever wrote the practice put that in there. It wasn't the veterinary medical board that threw that in there.
It would have to be, it's reg, so that's the only one that can do it.
Perhaps to make it consistent then, but with the legislation. But absolutely, our intention certainly was not to move casting and splinting to allow veterinary assistants to do it. It was to, already in an emergency, RVTs are allowed to put on a splint, not a cast. But it was going along with what we were talking about, allowing RVTs to give pain medication in addition to an emergency situation, or to relieve suffering, and that I just lost my train of thought. But the casting and splinting went along with that. That we were trying to loosen it a little bit for RVT so that it would not just be if the veterinarian was standing right there, then of course you could do it. But if the veterinarian was not present and a cast or splint needed to be put on, that an RVT would be able to do that.
So would we be considering moving casts and splints down to B?
You mean C2?
Yes, C2, that they could perform it under indirect supervision, which provides the cover for VA restriction.
So that would be one potential outcome here today if there's a motion to that effect.
I so move that we move casts and splints to C2.
Second.
Discussion from the committee? Discussion from the audience?
Grant Miller, CVMA. So it's confusing, maybe just to me, but Tara Welsh had mentioned this. So the first section relating to RVTs performing tasks is section B. And it says that these tasks have to be only performed under direct supervision. And in 2034, direct supervision means that the veterinarian examined the animal, directed the staff to do it, and the veterinarian is present in the facility when it happens. C1 is already confusing enough because it says that these may be done under indirect supervision, which means the veterinarian is not present. And it's exclusive. It says currently, and I know that this is not the way that we all understand it, but in the world, people are looking at it saying, okay, the only time an RVT can administer a controlled substance is when the veterinarian isn't there. If the veterinarian's there, then they can't do it.
It's not prescriptive.
It says may.
It's not
All right,
May.
so that's, as long as that's
permissive.
understood, because it's confusing for some when it says direct and indirect. Good.
I think anytime it's providing a discretion, so may is a discretion, it's saying you don't have to be under direct supervision here. This is discretion. So if it said an RVT shall perform procedures under indirect supervision, that would be prescriptive. And if you look at B, even though it uses may, it says only under direct supervision. So it's qualifying that the RVT doesn't have to do these things. They may do them, but if they do them, it's only under direct supervision. In C, we use may, and it's permissive because it doesn't restrict it to the use of indirect supervision.
So we have a motion and a second here to move casting and splinting under indirect supervision into C2. Just my question is, if this motion carries, does this in some way open a door for veterinary assistants to do casting or splitting? I just want to be very clear that there's no unintended consequence. Okay, just.
So to point this out for everyone, 2036.5A speaks to unregistered assistants, and they are prohibited from performing any of the functions or activities under 2036A, B, or C. So by applying casts and splits for RVTs from B to C, C is still prohibited, and a prohibited activity for veterinary assistants. So the prohibition remains. We haven't changed anything about what VAs can do. I just want to confirm that.
Okay, so I think that we are ready to vote, barring any other comments. Looks like there are none.
Okay, Dr. Klingborg.
Aye.
Dr. Drusis.
Aye.
Dr. Grant.
Aye.
Diana Woodward-Hagel.
Aye.
Dave Johnson.
Aye.
Jennifer Laredo.
Aye.
Christy Pulowski.
Aye.
Dr. Pollard.
Aye.
And Dr. Sullivan.
Aye.
Motion carries, so that concludes agenda item number 4, and thank you to the subcommittee for your hard work on that. Our game plan at this stage is going to be to take a 15-minute break. Then we are going to come back and we are going to discuss agenda item number 6, which I moved up. And then after we've discussed that, we will do lunch. We've got lots of other folks doing lunch right now, so we're going to push lunch back a little bit so we've got a little bit more room out there when it's our lunchtime. So 15-minute break, and let's get back to it.